pregnancy is a time for hope, excitement and joy. But for some women, it can also be a time for grief, despair and sorrow. Traditionally, pregnancy is calculated from the first day of the last menstrual period, even though actual conception takes place 2 weeks after that usually. The whole of pregnancy is generally divided into 3 parts called trimesters, and the first trimester is generally considered as early pregnancy, and that generally lasts from the beginning of the pregnancy till about 14 weeks. Early pregnancy complications or symptoms rather, apart from other symptoms, generally present with either pain or bleeding. Pain is mainly tummy pain, lower tummy pain. Could be on one side or generally around the whole of the lower tummy. In many cases, there could be common pregnancy, early pregnancy complications like miscarriage or ectopic pregnancy, which are in fact the 2 common complications without any symptoms. Miscarriages are unfortunately very common. About 15 to 20, and according to some studies almost 30%, so 1 in 3 pregnancies probably end in a miscarriage. This early in pregnancy, most of these miscarriages are due to one-off odd genetic or chromosomal abnormality. This of course does not mean that there is a genetic or chromosomal abnormality with any of the parents. And therefore, in most cases, fortunately, it does not recur. A recurrent miscarriage, that is 3 consecutive miscarriage, is fortunately very rare. In less than 1% of women suffer this. And therefore, routinely investigations are not done unless there is recurrent miscarriage. Of course, if there is recurrent miscarriage, one needs to investigate to look for a cause, and if we find a cause that can be treated, then of course it can prevent any further loss. Now, miscarriage, as I said before, can present with bleeding commonly, but can also present with lower abdominal pain. It can of course sometimes lead to excessive bleeding. Most bleeding in early pregnancy is, however, harmless, and it's often called implantation bleed. But any bleeding does need to be investigated to exclude miscarriages, but also ectopic pregnancies, and I'll come to that later. The first investigation that we usually do is a transvaginal or an internal scan, ultrasound scan. It is safe in early pregnancy. There has been extensive studies that have happened, and in an early ultrasound scan, generally around 4 weeks, we see a gestation sac, a pregnancy sac. Around 5 weeks, we may see a yolk sac, that's a ring-like structure within the sac. Around 6 weeks, we may see a fetal pole or a little embryo, an early baby. And around 7 weeks, we may see a heartbeat. In twins, this can be delayed. And in many cases, this timing can vary, as can vary the dates of the pregnancy, no matter how regular one's periods are. Now, despite all the improvement in the quality and the resolution of this ultrasound scan machines and the expertise, there are limits to what we can see in early pregnancy. And this can vary depending on a lot of other factors, depending on the location and the site and the size of the sac. Now, if one has bleeding, but on an ultrasound scan the pregnancy is fine, then it is usually called a threatened miscarriage. Usually the pregnancy continues well unless the bleeding increases in amount. Sometimes, however, there may not be any symptoms and a miscarriage is only incidentally picked up on a routine scan, usually around 11 or 12 weeks. This is called a missed miscarriage. Now, occasionally, one may see on an ultrasound scan a sac, a pregnancy sac, but may not see a pregnancy within it. This is generally called a pregnancy of unknown viability. So we know that the pregnancy is in the right place in the womb, but we're not sure whether the pregnancy is okay or not. In these cases, we generally repeat the scan in a week or two, where we expect to find a more definitive answer. If the pregnancy sac is more than 25 millimeters in diameter, but we do not see anything within the sac, then we consider it as a miscarriage, or if a sac has not grown in a week's time in size. Similarly, if we find a fetal pole or a baby in there, an early embryo, which is at least 7 millimeter in length, and we do not see a heartbeat, or the embryo does not change in size in a week's time or so, then again we consider it as a miscarriage. If there is a miscarriage, there are various options of treatment, of course, which can be medical or surgical, and in some cases they spontaneously resolve. As I said, many a times, despite the good resolution in scanning and expertise with scanning, we may not have a definitive answer with one ultrasound scan. And if we do not see a pregnancy, because we're talking in terms of a few millimeters, then sometimes we have to do some additional tests, mainly a blood test, blood hormone of pregnancy called an HCG. Generally, the HCG hormone, that is a blood test, nearly doubles in 36 to 48 hours time in a normal early viable pregnancy. So even if we don't see a pregnancy in the womb, the chances are that the pregnancy is fine, and we repeat the scan later on. If the HCG level or the hormone level in the blood test falls, then it's likely that the pregnancy is failing, unfortunately, which means it's either a miscarriage, or it could even be an ectopic pregnancy, where a pregnancy is outside the womb, most commonly in the fallopian tubes, but it is resolving on its own, which means that it's essentially a miscarriage of a pregnancy that's not in the womb. If the HCG or the hormone levels neither rises nor falls enough, then we suspect an ectopic pregnancy. However, none of these are confirmatory. An ectopic pregnancy can present with a rising HCG level or a falling HCG level as well. So it's a combination of various elements that we look into while diagnosing or suspecting an ectopic pregnancy. Ectopic pregnancies are pregnancies that occur outside the womb. All pregnancies start in the fallopian tube, and then ultimately it travels down into the womb to lodge there and continue. Ectopic pregnancies commonly get stuck in the fallopian tube and starts growing there, but they cannot grow in the tube much longer. So in most cases around 8-9 weeks, they start bleeding, and occasionally the tube can even rupture, causing massive and potentially life-threatening bleeding that is internal inside the tummy and therefore not visible outside. Therefore, it is extremely important that any tummy pain in early pregnancy, particularly if it doesn't go away with ordinary painkillers or one feels unwell, one should immediately be seen by a doctor, and an ectopic pregnancy needs to be excluded. Ectopic pregnancies can be treated if detected early on an ultrasound scan. And as I said, ectopic pregnancies can be in the tube commonly, but it can also be in other structures like the ovaries and occasionally in the neck of the womb, in the cervix and other places. If detected early, in many cases can be treated with an injection of a substance called methotrexate. Very rarely we have to repeat it after a week. If methotrexate is given, of course, to monitor whether it's working and the ectopic pregnancy is resolving, one needs to do the blood tests for the HCG hormone so as to ensure that it's coming down to 0. Very rarely an ectopic pregnancy may resolve on its own, and we just need the hormone monitoring, again the blood test, to ensure that. In most cases, however, particularly where there is a risk of the ectopic pregnancy rupturing or already has ruptured, one needs a surgery. Usually it's a keyhole surgery and the ideal treatment or the optimum treatment is generally removing the affected tube. It's partly because if one has an ectopic pregnancy in a fallopian tube, there is a greater chance that the tube was probably already damaged either from a previous infection or from a previous surgery, or sometimes without any known cause. And once an ectopic pregnancy forms in that, the tube is further damaged. And therefore, leaving a damaged tube by taking out the ectopic pregnancy only increases the risk of having another ectopic pregnancy in the tube more. In rare cases, however, where the other tube is either absent, has been removed before, or is damaged, and one wants to preserve the affected tube to preserve fertility, one may just remove the ectopic pregnancy through a small cut in the tube and preserve the tube. In these cases, we usually do hormone levels, the blood tests, to again ensure that all the pregnancy tissue, the ectopic pregnancy tissue, has been removed. Sometimes, as with a miscarriage, ectopic pregnancies also may not be diagnosed by just a single ultrasound scan. If we don't see any pregnancy on an ultrasound scan inside the tummy, neither in the womb nor outside the womb, but the urine or the blood test suggests that one is pregnant, we call it a pregnancy of unknown location. We don't know where the pregnancy is. The assumption is that it may be an ectopic pregnancy, and simply because an ectopic pregnancy is potentially can be a more dangerous situation than a miscarriage. It doesn't necessarily mean that that is more likely. And therefore, we then do hormone levels, as I said before, and repeat the scans when needed to check for an ectopic pregnancy. Lastly, a very rare complication of early pregnancy is called a molar pregnancy or a trophoblastic disease. This is an abnormality of the tissues that would have eventually formed the placenta. And these tissues grow at a very rapid rate and form little grape-like sacs or structures within the womb. This can cause heavy bleeding, heavy vomiting in early pregnancy, and sometimes raise the blood pressure as well. They need to be removed or treated surgically. Most often there is no baby inside, but very rarely there could be an early pregnancy as well. This is a condition where the tissues that are removed needs to be checked under the microscope, and sometimes in certain conditions where there is a greater risk of this recurring or spreading, one may need very close follow-up and further treatment if needed. Thank you.